Good morning, everyone. Respected teachers, batchmates, and juniors, I am going to present seminar on paraneoplastic syndrome. Introduction. The term paraneoplastic syndrome refers to symptoms or signs resulting from damage to organs or tissues that are removed from the site of a malignant neoplasm or its metastasis. Paraneoplastic syndromes can affect most organs and tissues. The term paraneoplastic comes from the Greek roots para, alongside or near, neo, new, and plastic, being formed or shaped. Thus, the meaning beside a new formation or cancer. Definition. A paraneoplastic syndrome is a disease or symptom that is the consequence of cancer in the body but not due to the local presence of the cancer cells. These phenomena are mediated by humoral factors such as hormones or cytokines excreted by the tumor cells or by an immune response against the tumor. These syndromes can affect any organ or tissue, including the liver, skin, and muscles, but the nervous system itself is a common sign. In a broad sense, these syndromes are collection of symptoms that result from substances produced by the tumor and they occur remotely from the tumor itself. Etiology. These syndromes may occur in up to 10 to 15% of the malignancies and they may be the first or most prominent manifestation. There is no race predilection, no sex predilection known so far. Patients of all ages may be affected by cancers and their related paraneoplastic syndromes. Importance of diagnosis. The importance of the paraneoplastic syndromes and the elucidation of their mechanisms are important for many reasons. Their appearance may be the first sign of a malignancy, which allows it early detection in curable state. They may stimulate metastatic disease and prevent patient from having curative therapy. Conversely, treatable complications of malignancies, example metastatic disease infection, may be ascribed to a paraneoplastic syndrome, leading to withholding of appropriate therapy. The frequency of neurological paraneoplastic syndromes is sometimes less than zero point 0.5 per 1 lakh population per year. Over the last 10 years, there has been increasing understanding of the immunological mechanism and many new antigens antibodies have been described. This may be the earliest manifestation of an occult neoplasm. They cause significant clinical problems and may even be lethal. They may mimic metastatic disease and therefore confound treatment. Pathophysiology. When a tumor arises, body may produce antibodies to fight and destroy the tumor cells. Unfortunately, the antibodies cross-react with the normal tissue, destroy them to produce paraneoplastic syndromes. Paraneoplastic syndromes result from production and release of physiologically active substance from the tumor cells. It may produce hormones, precursors, enzymes, or cytokines. Some cancer cells produce proteins that are physiologically expressed in utero in embryonic and fetal cells but not in adult cells. These serve as tumor markers. Example, CEA alpha fetoprotein. This is the figure showing the pathogenesis of the paraneoplastic syndrome. These are the tumor cells which react with the cells in the body, for example, dendritic cells, result in the production of CD8 T cells, CD4 T cells, and B cells, and finally plasma cells. These plasma cells and cytotoxic T cells produces antibodies which either act directly with the neuromuscular junction and they can even cross the blood brain barrier, and the antibodies which are further produced can also react with the neurons. Tumor cells are immunogenic and lead to activation of both cell mediated and humoral immune system. It has been observed that cytotoxic T cells recognize antigens on tumor cells and attack those cells or generate antibodies against tumor cells. However, the body's immune system can also attack normal tissue with a similar antigen presentation and lead to symptoms. Most cases exhibit paraneoplastic syndrome with immunologic mechanism. However, there are non-immunologic mechanisms of paraneoplastic syndrome. The paraneoplastic syndrome has heterogeneous manifestation affecting multiple organ systems in the body. Clinical manifestation does not necessarily associate with the clinical or pathological stage of the underlying malignancy, nor is it a prognostic indicator. Coming to the mechanisms, first the immunologic mechanism. Cell mediated immunity, T cells attack tumor cells antigen as well as similar antigens in normal cells. Paraneoplastic syndrome antibodies produce antibodies which are also known as onconeural antibodies that are directed against a target antigen, that is onconeural antigen. Few examples are type 1 antineural nuclear antibodies, type 2 antineuronal nuclear antibodies, collapsing response mediator protein 5, Purkinje cell cytoplasmic antibody type 1, anti-amphiphysin, anti-recoverin, anti-bipolar cell of the retina, M-methylene D-aspartate receptor antibodies, acetylcholine receptor antibodies, gamma aminobutyric acid A receptor antibodies. The second is a non-immunologic mechanism. Tumor cells produce hormones or cytokines leading to metabolic abnormalities such as hyponatremia due to antidiuretic hormone or hypercalcemia due to parathyroid hormone related peptide. In addition, hematological malignancies producing immunoglobulins affect the peripheral nervous system manifested as peripheral neuropathy. Patients with a definite paraneoplastic syndrome include those with, these are the few categories in which they are divided. Category A classical syndrome, that is encephalomyelitis, limbic encephalitis, subacute cerebellar degeneration, opsoclonus myoclonus, subacute sensory neuropathy, chronic gastrointestinal pseudo-obstruction, LEMS or dermatomyositis, and the cancer that develops within 5 years of the diagnosis of the neurological disorder regardless of the presence of paraneoplastic antibodies. Second category, a non-classical syndrome that objectively improves or resolves after cancer treatment, provided that the syndrome is not susceptible to spontaneous remission. A non-classical syndrome with paraneoplastic antibodies, well characterized or not, and the cancer that develops within 5 years of the diagnosis of the neurological disorder. Category D, a neurological syndrome with well characterized paraneoplastic antibodies, that is anti-Hu, anti-Yo, anti-Re, anti-amphiphysin, anti-CV2, anti-MAR2. Patients with possible paraneoplastic syndrome include those with a classical syndrome without paraneoplastic antibodies and no cancer but a high risk to have an underlying tumor. Example, smoking habit. B, a neurological syndrome, classic or not, without cancer but with partially characterized paraneoplastic antibodies. C, a non-classical neurological syndrome, no paraneoplastic antibodies, and cancer that presents within 2 years of the neurological syndrome. Before coming to the final diagnosis of paraneoplastic syndrome, we have to rule out few differentials. So let's see what are the differential diagnoses. The importance and frequency of the paraneoplastic syndrome make it imperative to establish the appropriate diagnosis. If the cause of the paraneoplastic syndrome is unknown, this may mean excluding all other known causes of the syndrome. In general, paraneoplastic syndromes must be differentiated from direct invasion by the primary tumor or its metastasis, obstruction caused by tumor or tumor products, vascular abnormalities. Infections, fluid and electrolyte abnormalities. Toxicity of cancer therapy including cytotoxic chemotherapy, radiation therapy, immunotherapy, or antibiotic therapy. Clinical examination, which includes history, asking for smoking habits, weight loss, night sweats, fever. Physical examination, palpation of pathological lymph nodes, rectal and pelvic examination, and palpation of breast and testes. Laboratory findings, high resolution computed tomography of chest, abdomen, and pelvis. If the CT scan remains negative, whole body fluorodeoxyglucose positron emission tomography or PET is recommended to detect an occult tumor or its metastasis. Mammography or ultrasound of the testes or pelvis. When all tests remain negative, repeat evaluation at 3 to 6 months intervals for 2 to 3 years is recommended. Paraneoplastic disorders have autoantibodies against several tissues of the body. These antibodies should be detected from the laboratory tests. The paraneoplastic antibodies are generally divided into three categories. First, the well-characterized antibodies that are reactive with molecularly defined onconeural antigens. These antibodies are strongly associated with cancer and have been detected unambiguously by several laboratories in reasonable number of patients with well-defined neurological syndromes. Second, the partially characterized antibodies that are those with an unidentified target antigen and those that have either been described by a single group of investigators or have been reported in only a few patients. Third, the third group consists of antibodies that are associated with specific disorders but do not differentiate between paraneoplastic and non-paraneoplastic cases. This is the table showing antibodies, clinical syndromes, and associated tumor. First are well-characterized paraneoplastic antibodies. Anti-WHO. Clinical syndromes are encephalomyelitis, limbic encephalitis, sensory neuropathy, subacute cerebellar degeneration, autonomic neuropathy. Tumors associated small cell lung cancer, neuroblastoma, and the tumors of prostate. Anti-Yo. Subacute cerebellar degeneration associated with tumors of ovary and breast. Anti-CV2. Encephalomyelitis, chorea, limbic encephalitis, sensory neuropathy, sensory motor neuropathy, optic neuritis, subacute cerebellar degeneration, autonomic neuropathy. Tumors of thymoma or small cell lung cancer. Anti-RI, anti-RE. Opsoclonus myoclonus, brainstem encephalitis, tumor of breast and small cell lung cancer. Anti-MAR2, limbic, diencephalic, brainstem encephalitis, subacute cerebellar degeneration, tumors of testes and lung. Anti-ampifysin, stiff person syndrome, encephalomyelitis, subacute sensory neuropathy and sensory motor neuropathy, tumors of breast, small cell lung cancer. Anti-recoverin, cancer associated retinopathy. The tumor is small cell lung cancer. Second category, partially categorized antibodies. Anti-TR, subacute cerebellar degeneration, Hodgkin's disease. ANNA3, encephalomyelitis, subacute sensory neuropathy, small cell lung cancer. PCA2, encephalomyelitis, subacute cerebellar degeneration, small cell lung cancer. Anti-ZIC4, subacute cerebellar degeneration, small cell lung cancer. Anti-mGlu1, subacute cerebellar degeneration, Hodgkin's disease. Third category, antibodies that occur with or without cancer. Anti-VGCC, Lambert-Eaton myasthenic syndrome, subacute cerebellar degeneration, small cell lung cancer. Anti-AChR, myasthenia gravis, thymoma. Anti-NACHR, subacute autonomic neuropathy, small cell lung cancer. Anti-VGKC, limbic encephalitis, neuromyotonia, tumors are thymoma and small cell lung cancer. What are the clinical syndromes? The paraneoplastic syndromes are divided into the following categories: miscellaneous, non-specific syndromes, endocrine, neurologic, hematologic, renal, gastrointestinal, cutaneous, rheumatologic, and neuromuscular syndromes. Let's see all of them one by one. First, miscellaneous. Non-specific syndromes can precede the clinical manifestation of the tumor, and this occurrence is a negative prognostic factor. Fever, dysgeusia, anorexia, and cachexia are included in this category. Generally, fever occurs in the evening and is of continual remittent type. Dysgeusia manifests in a variety of ways from ageusia to aversion to protein, in particularly meat proteins. Anorexia is a common disorder among patients with paraneoplastic syndromes and is responsible along with dysgeusia for weight loss and even cachexia. Endocrinopathies. The secretory activity of such tumor is referred to as ectopic hormone production. The paraneoplastic endocrine syndromes generally result from tumor production of hormones or peptide that lead to metabolic disarrangements. Thus, successful treatment of the underlying tumor often improve these conditions. The most common paraneoplastic syndromes responsible cancer are not of endocrine origin. These include Cushing syndrome, SIADH, hypercalcemia, hypoglycemia, polycythemia vera, hyperaldosteronism, carcinoid syndrome. SIADH. Gait disturbances, falls, headache, nausea, fatigue, muscle cramps, anorexia, confusion, lethargy, seizures, respiratory depression, and coma. These are the few clinical presentations. Laboratory findings are hyponatremia, which is mild, sodium ranging from 130 to 134 milliequivalents per liter. Moderate means the sodium will be in the range of 125 to 129, and in severe cases the sodium will be less than 125. Increased urine osmolality, that is more than 100 milliosmoles per kg. Associated cancers are small cell lung cancer, mesothelioma, bladder, urethral cancers, endometrial, prostate, oropharyngeal, thymoma, lymphoma, Ewing sarcoma, brain, GI, breast, and adrenal cancers. Treatment is restriction of fluids, dimethylocyclamine, covicaptan, tolvaptan, and hypertonic saline. Second is hypercalcemia. The clinical presentation is altered mental status, weakness, ataxia, lethargy, hypertonia, renal failure, nausea, vomiting, hypertension, bradycardia. The laboratory findings will be hypercalcemia. In mild cases, 10.5 to 11.9 mg per deciliter, moderate 12 to 13.9 mg per deciliter, and in severe cases the calcium will be more than 14 mg per deciliter. There will be either normal PTH level or elevated PTH levels. Associated cancers are breast, multiple myeloma, renal cell cancer, squamous cell cancers, lymphomas, ovarian and endometrial cancers. Treatment includes normal saline, furosemide, pamidronate, zoledronate, prednisone, calcitonin, or hemodialysis. The third is Cushing syndrome. The clinical features will be muscle weakness, peripheral edema, hypertension, weight gain, centripetal fat deposit distribution. In laboratory findings, there will be hypokalemia, usually less than 3 millimoles per liter, elevated baseline serum cortisols, more than 29 microgram per deciliter. Normal to elevated midnight serum ACTH, that is more than 100 nanogram per liter, which is not suppressed by dexamethasone. The cancers associated with it are small cell lung cancer, bronchial carcinoid, neuroendocrine lung tumors account for 50 to 60% of the cases of paraneoplastic Cushing syndromes, thymoma, medullary thyroid cancer, GI, pancreatic, adrenal, ovarian cancers. Treatment is ketoconazole, octreotide, mitripone, mitotone, mifepristone, and lastly adrenalectomy. Hypoglycemia, sweating, anxiety, tremors, palpitations, hunger, weakness, seizures, confusions, and coma. These are the clinical manifestations which the patients present with. In laboratory findings, for non-islet cell tumors, hypoglycemia, the low glucose level or low insulin is often less than 1.44 to 3.60 micro international units per ml. Low C-peptide levels, elevated IGF-2 and IGF-1 ratio. For insulinomas, low glucose, elevated insulin, elevated C-peptide, normal IGF-2 to IGF-1 ratios. Associated cancers are mesothelioma, sarcomas, lung cancers, and GI cancers. Treatment is infusion of glucose, dexamethasone, prednisone, glucagon infusion, octreotide, human growth factors, growth hormones. Polycythemia vera. Patients present with polycythemia, the mechanism behind it is excessive production of erythropoietin. The underlying carcinomas include renal cell carcinoma, cerebellar carcinoma, hepatocellular carcinoma. Carcinoid syndrome. It may affect the different organs like heart, liver, gastrointestinal symptoms, skin, respiratory system, and retroperitoneal organs. In the heart, it may cause pulmic tricuspid valve stenosis, endocardial fibrosis. Skin, cutaneous flushes, apparent cyanosis. In liver, hepatomegaly. Respiratory symptoms might be cough, wheezing, dyspnea. In gastrointestinal symptoms, it may cause diarrhea, cramps, nausea, vomiting. In retroperitoneal and pelvic fibrosis may be caused. The diarrhea is mostly caused by the serotonin excess, also caused by histamine, calcarein, prostaglandin, substance P, and motilin. Flushing, which is seen in 94%, is linked to several hormonal factors like tachykinins, serotonin, and histamine, provoked by, example, nut and cheese and certain drugs and alcohol. Carcinoid heart disease, seen in 40%, is characterized by so-called plaques at the right side of the heart with an involvement of the tricuspid and pulmonary valves and endocardium. Pellagra, characterized by dermatitis, diarrhea, or dementia, results from niacin deficiency. Intermittent bronchial obstruction accompanies flushing. Carcinoid crisis, rare, potentially fatal, evoked by anesthesia or surgery if not treated sufficiently with somatostatin analogues. Cushing syndromes caused by ectopic ACTH production accounts for 10 to 20% of the Cushing syndromes, most commonly seen by small cell lung cancer, more than 50% in most of the common cause. Less marked fat gain and centripetal fat redistribution, fluid retention, hypertension, metabolic alkalosis, glucose intolerance, and psychosis, increased pigmentation, marked skin fragility, and easy bruising, severe hypokalemia, high plasma ACTH level, that is more than 100 pg per ml, and do not respond to glucocorticoid suppression. Next category is paraneoplastic neurologic syndromes. Paraneoplastic neurologic syndromes result from immune cross-reactivity between tumor cells and components of the nervous system. In response to a developing cancer, a patient produces tumor directed antibodies known as onconeural antibodies. Because of antigenic similarity, these onconeural antibodies and associated onconeural antigen specific T lymphocytes inadvertently attack components of the nervous system as well. In contrast to paraneoplastic endocrine syndromes, paraneoplastic syndromes are detected before cancer is diagnosed in 80% of the cases. Because tumor cells themselves do not directly produce the causative agents of the paraneoplastic syndrome, and because onconeural antibodies may cause permanent damage, successful cancer treatment does not necessarily result in neurologic improvement. Immunosuppressive therapy is a mainstay of paraneoplastic syndrome treatment, but success is variable. Limbic encephalitis. Clinical presentation: mood changes, hallucination, memory loss, seizures, hypothalamic symptoms like hyperthermia, somnolence, endocrine dysfunction. Associated antibodies: anti-Hu, anti-MA2, anti-CRMP5, anti-ampifysin. Diagnostic studies: EEG, which shows epileptic foci of temporal lobe or focal generalized low activity. FDG PET, increased metabolism in temporal lobe. MRI, showing hyperintensity in the medial temporal lobe. CSF analysis shows pleocytosis, elevated protein, elevated IgG, and oligoclonal bands. Associated cancers: small cell lung cancer, testicular germ cell cancer, breast cancers, thymoma, teratoma, Hodgkin's lymphoma. Treatment is IV immunoglobulins, methylprednisolone, prednisone, plasma exchange therapy, rituximab. Paraneoplastic cerebellar degeneration. Ataxia, diplopia, dysphagia, dysarthria, dizziness, nausea, vomiting. Antibodies associated: anti-Yo, anti-Hu, anti-CRMP5, anti-MA, anti-TR, anti-RE, anti-VVG, anti-mGlu-R1. Diagnostic findings: FDG PET scan shows increased metabolism in early stages and then decreased metabolism in late stages in cerebellum. MRI shows cerebellar atrophy. Associated tumors: small cell lung cancer, gynecologic tumors, Hodgkin's lymphoma, breast cancers. Treatment is same like IV immunoglobulins, methylprednisolone, plasma exchange, cyclophosphamide, and rituximab. Lambert-Eaton myasthenia syndrome, LEMS. Clinical presentation: lower extremity proximal muscle weakness, fatigue, diaphragmatic weakness, bulbar symptoms like litosis, impotence, dry mouth. Antibodies: anti-VGCC. Diagnostic investigations is EMG, which shows low compound muscle action potential amplitude, decremental response with low rate of stimulation but incremental response with high rate of stimulation. Associated cancers: small cell lung cancer, prostate, cervical, lymphomas, and adenocarcinomas. Treatment includes prednisolone, azathioprine, IV immunoglobulins, and plasma exchange. Myasthenia gravis. Clinical presentation: fatigable weakness of voluntary muscles, example oculobulbar and limbs, diaphragmatic weakness. Antibodies: anti-AChR. Diagnostic test: EMG, decremental response to repetitive nerve stimulation. Cancer which is associated as thymoma. Treatment: thymectomy, prednisone, azathioprine, cyclosporin A, tacrolimus. Autonomic neuropathy. Clinical presentation: autonomic neuropathy, often subacute in onset, involving sympathetic, parasympathetic, and enteric systems, orthostatic hypotension, GI dysfunction, dry eyes or mouth, bowel bladder dysfunction, altered pupillary light reflexes, loss of sinus arrhythmia, constipation, nausea, vomiting, dysphagia, weight loss, abdominal distension. Associated antibodies anti-U, anti-CRMP5, anti-NRACHR, anti-ampifysin. Diagnostic studies, abdominal radiography, barium studies, on CT, GI dilatation but no mechanical obstruction, esophageal manometry shows achalasia or spasms. Associated cancers are small cell lung cancer, thymoma. Treatment for orthostatic hypotension, water, salt intake, fluorocortisone, caffeine should be given. Subacute or peripheral sensory neuropathy. Clinical presentation, paresthesia, pain, upper extremities, followed by ataxia, multifocal asymmetric distribution, all sensory modalities decreased but especially deep sensation, asthetosis of hands, deep tendon reflexes decreased or absent. Onset is for weeks to months. Associated antibodies are anti-U, anti-CRMP5, anti-ampifysin. Diagnostic studies, NCS, reduced or absent sensory nerve action potentials. CSF analysis shows pleocytosis, high IgG, oligoclonal bands. Associated cancers, lung cancer, small cell carcinoma of lung, breast, ovarian cancers, carcinoma, Hodgkin's lymphoma. Paraneoplastic hematological syndromes. Paraneoplastic hematological syndromes are rarely symptomatic. These conditions are usually detected after a cancer diagnosis and are typically seen in association with advanced disease, rarely require specific therapy, and may improve with successful treatment of the underlying malignancy. Eosinophilia. Dyspnea, wheezing with a clinical presentation. Laboratory findings, hypereosinophilia, elevated IL-5, that is interleukin 5, interleukin 3, interleukin 2 and GM-CSF. Associated cancers, Hodgkin's lymphoma, non-Hodgkin's lymphoma, chronic myeloid leukemia, acute lymphocytic leukemia, lung cancers, thyroid, GI, that is pancreatic, colon, gastric, liver, renal, breast and gynecologic cancers. Treatment, corticosteroids, that is prednisolone. Granulocytosis. Asymptomatic, no symptoms or signs of leukocytosis such as neurologic deficits or dyspnea. Laboratory findings, granulocytes, that is neutrophilic count more than 8 into 10 to the power of 9 per lakh, typically without a shift to immature neutrophil forms, elevated LAP and elevated serum GCSF. Associated cancers, GI, lung, breast, gynecologic, brain, Hodgkin's lymphoma and sarcomas. Pure red cell aplasia. Clinical presentation, dyspnea, pallor, fatigue, synchrome. Laboratory findings, anemia, hematocrit less than 20, low or absent reticulocytes, bone marrow with nearly absent erythroid precursors, platelet and white blood cell count is normal range. Associated cancers, thymoma, leukemia or lymphoma, myelodysplastic syndrome. Treatment is blood transfusion, prednisone, cyclosporin, cyclophosphamide, rituximab, plasma exchange, splenectomy. Thrombocytosis. Asymptomatic or no bleeding or clotting abnormalities. Laboratory findings, elevated platelet count greater than 400 into 10 to the power of 9 per liter, elevated interleukin 6. Associated cancers, GI, lung, breast, gynecologic, lymphoma, renal cell, prostate, mesothelioma, glioblastoma, head and neck. Renal manifestations. Patient with tumors that secrete adrenocorticotropic hormone, ACTH or ACTH-like substances may have hypokalemic neuropathy, which is characterized by urinary potassium leakage of more than 20 milliequivalent per 24 hours. This occurs in 50% of the individuals with ACTH secreting tumors of the lung. Example, small cell lung cancer. Other types of tumors that can produce ACTH, antidiuretic hormone, and gut hormones may cause hypokalemia, hyponatremia, or hypernatremia, hyperphosphatemia, and alkalosis or acidosis. Nephrotic syndrome is observed, although seldom, in patients who have Hodgkin's lymphoma, non-Hodgkin's lymphoma, leukemias, melanomas, or malignancies of lung, thyroid, colon, breast, ovary, or pancreatic head. Patients with myeloma, renal cell carcinoma, or lymphoma present rarely with secondary amyloidosis of the kidneys, heart, central nervous system. Clinical picture of secondary amyloidosis is related to renal and cardiac injuries. Coexistence of subacute thyroiditis and renal cell carcinoma as paraneoplastic syndrome. Gastrointestinal manifestations. Watery diarrhea accompanied by an electrolyte imbalance leads to asthenia, confusion, and exhaustion. These problems are typical of patients with proctosigmoid tumors and of medullary thyroid carcinoma that produce several prostaglandins, especially PGE2 and F2, that lead to malabsorption and consequently unavailability of nutrients. These alterations also can be observed in patients with melanomas, myelomas, ovarian tumors, pineal body tumors, and lung metastasis. Coming to paraneoplastic dermatological syndromes. Acanthosis nigrans, clinical presentation velvety hyperpigmented skin, papillomatous changes involving mucous membranes and mucocutaneous junctions, rugose changes on palms and dorsal surface of large joints. Diagnostic study, skin biopsy, histology shows hyperkeratosis and papillomatosis. Associated cancers, adenocarcinomas of the abdominal organs, and gynecological cancers. Topical steroid is the treatment. Dermatomyositis. Clinical presentation, heliotrope rash, Gotoron papules, that is the scaly papules on bony surfaces, erythematous rash on face, neck, chest, back, or shoulders. Rash may be photosensitive, proximal muscle weakness, swallowing difficulty, respiratory difficulty, muscle pain. Laboratory findings, elevated serum CK, AST, ALT, LDH, and aldolase. EMG show increased spontaneous activity with fibrillations, complex repetitive discharges, and positive sharp waves. Muscle biopsies, perivascular or intravesicular septal inflammation and perivesicular atrophy. Associated cancers, ovarian, breast, prostate, lung, colorectal, non-Hodgkin's lymphoma, nasopharyngeal. Erythroderma. Clinical presentation, erythematous exfoliating diffuse rash. Diagnostic test, skin biopsy, histology shows dense perivascular lymphocytic infiltration. Associated cancers, chronic lymphocytic leukemia, cutaneous T-cell lymphoma, GI cancers like colorectal, gastric, esophageal, gallbladder, adult T-cell leukemia, lymphoma, myeloproliferative disorders. Sweet syndrome, acute febrile neutrophilic dermatosis. Clinical features, acute onset of tender erythematous nodule, papules, plaques or pustules on extremities, face or upper trunk. Neutrophilia, fever and malaise. Laboratory test is skin biopsy which shows histology showing polymorphous nuclear cell dermal infiltration. Associated cancer, leukemia, non-Hodgkin's lymphoma, myelodysplastic syndrome, genitourinary breast, GI, multiple myeloma, gynecologic, testicular and melanomas. Paraneoplastic rheumatological syndromes. Paraneoplastic pemphigus. Severe cutaneous blisters and erosions on trunk, soles and palms. Severe mucosal erosions including stomatitis. Serum antibodies to epithelia. Skin biopsy shows histology shows keratinocyte necrosis, epidermal acantholysis, and IgG. Associated cancers, non-Hodgkin's lymphoma, chronic lymphocytic leukemia, thymoma, Castleman's disease, follicular dendritic cell sarcomas. Polymyalgia rheumatica, limb girdle pain and stiffness. Laboratory findings, elevated ESR and CRP. Associated cancers, leukemia, lymphoma, myelodysplastic syndrome, colon, lung, renal and prostate of breast. Hypertrophic osteoarthropathy. Clinical presentation, subperiosteal new bone formation on phalangeal shaft, synovial effusion, pain, swelling along the affected bones and joints. Clinical findings, periosteal reaction along the long bones is seen on plain X-ray. Nuclear bone scan shows intense and asymmetric uptake in long bones. Tumors, intrathoracic tumors, metastasis to lung, metastasis to bone, nasopharyngeal carcinoma, rhabdomyosarcoma. Leukocytoclastic vasculitis. Clinical presentation, ulceration, cyanosis and pain over affected regions, palpable purpura often of lower extremities, renal impairment, peripheral neuropathy. Skin biopsy shows histology, fibrinoid necrosis, endothelial swelling, leukocytoclasis and RBC extravasation. Associated cancers, leukemia, lymphoma, myelodysplastic syndrome, colon, lung, urologic multiple myeloma and rhabdomyosarcoma. Now let's see about the treatment of the paraneoplastic syndrome. Treatment varies with the type and location of the paraneoplastic syndrome. Two treatment options exist. The first therapeutic option is treatment of the underlying tumor based on the usual surgery, radiation or chemotherapy. The therapeutic protocols are those that generally are applied to the neoplastic disorders without the presence of the paraneoplastic syndromes. The second option is the treatment of the presumptive immune-mediated disorder is based on immunosuppression by intravenous immunoglobulins, steroids and other immunosuppressive drugs or by plasma exchange. This treatment should be reserved for patients with clearly identifiable antibodies in their serum. The surgical procedures that usually are applied to neoplastic disorders are also applied to those with paraneoplastic syndromes. Most paraneoplastic syndromes do not respond to treatment of either the tumor or the immune system. A person with such a condition may remain substantially disabled even when the tumor that created the problem has been treated effectively. Despite the immunological etiology of most of the paraneoplastic syndrome, the results of immunologic therapy have been disappointing. Exceptions are the neurological syndromes associated with paraneoplastic antibodies that are directed against antigens that are located at the surface of the cell. These include not only disorders of the peripheral nervous system but also anti-MUGR and associated PCDs and anti-ampifysin associated stiff person syndrome. Immunotherapy modalities that are recommended for these disorders include plasma exchange, immunoabsorption, steroids, IVIG, that is immunoglobulins. Prognosis. Since paraneoplastic syndromes differ widely from individual to individual, prognosis may vary greatly. For example, DIC indicates a poor prognosis, while hypertrophic osteoarthropathy is one of the few paraneoplastic syndromes that improve a patient's prognosis. Some disorders such as Lambert-Eaton myasthenic syndrome and myasthenia gravis respond well to immunosuppression and subsequently to treatment of the underlying tumor. The peripheral neuropathy associated with osteosclerotic myeloma generally resolves when the tumor is treated with radiopathy. A few disorders such as opsoclonus myoclonus in adults may respond to treatment of the underlying tumor, immunosuppression or both, or they may resolve spontaneously. In many instances, it is not clear whether the paraneoplastic syndrome resolves spontaneously or in response to treatment. Patients with paraneoplastic syndrome appear to have a better prognosis with respect to the tumor than do patients with the same type of tumor who do not have paraneoplastic syndromes. Conclusion. As the number of patients with cancer grows and as these patients live longer, the incidence of paraneoplastic syndromes will likely increase. These conditions affect the presentation, clinical course, and treatment of cancer. As a result of recent diagnostic and therapeutic advances, many paraneoplastic syndromes are currently well defined, have a clear pathogenesis, and have effective treatment options. The ability to recognize and treat paraneoplastic syndromes may have a substantial effect on clinical outcomes, ranging from earlier cancer diagnosis to improved quality of life to increased delivery of tumor directed therapy. Furthermore, ongoing research into these disorders may shed light on the mechanism of tumor development, maintenance, and proliferation. Summary: paraneoplastic syndromes are uncommon diseases with different pathogenesis and clinical manifestation. Although these disorders are rare, the investigations of paraneoplastic syndromes have been fruitful for the clinical neurologist and clinical oncologist and neuroscientist. The oncologist who encounters a patient with an antibody positive paraneoplastic syndrome not only knows the area of the body in which to look for the tumor but also can estimate that the growth of the tumor is likely to be more indolent than the same tumor in a patient without paraneoplastic syndrome. This knowledge may have an influence on the therapy that the oncologist prescribes. The better described pathogenesis is the autoimmune one, characteristic of the neurological, for which the clinical and laboratory findings have been well supported. Paraneoplastic syndromes are important because their identification permits an early diagnosis of tumor and rapid treatment, with largely improved prognosis and life expectancy for the patient. More studies are necessary for a better definition of their clinical aspects and pathogenesis and to delineate standard guidelines for a diagnostic therapeutic approach of these diseases. These are my references. Thank you.